All right, let's move on to trochanteric fractures. And again, a recap. In the OTA classification, these will be the A types, your B types will be the neck fractures, and your C types will be the intra-articular fractures, the head. All right, so I'm going to be focusing on this slide again because I think really understanding the classification just gives you the whole treatment algorithm, and you really don't have any questions if you understand this slide. So for trochanteric fractures, they really got it. I think they got a lot of it right in this update of the classification. You got your type A1s. You have it's what we used to call per-trochanteric, or where the main fracture line goes through the trochanters, but it's a simple fracture type. Okay. So, so you see, there's this type, which is just a lesser or just a greater of, which is you know, it's an outlier here. But these are the two trochanteric fractures, and you have and they included even the lesser troch off here, as long as it's a simple fracture pattern in the intertrochanteric in the per-trochanteric area. Your A2s are going to be the same thing, only with comminution. And your A3s are going to be when the main fracture line is in the reverse direction or in between the trochanters. So, like I said, one way of saying is these are the per-trochanteric fractures, and these are the inter-trochanteric fractures, or the between the trochanter fractures, which are also previously called, and some people still call it, a reverse obliquity type of fracture. Another way of looking at it, and they included, this is from the 2018 update, is just focusing on the lateral wall. And the lateral wall, and they even have a ridiculously complex way of measuring the lateral wall width, which they put in here, which is, I don't know, 3 centimeters from I don't know what to I don't know where, and then making sure it's less than 20.5 millimeters, which is obviously ridiculous. But you can just imagine a hip screw and a trajectory and just measure it, you know, if it's more or less than 2 centimeters, which will give you, is it an intact lateral wall or is it a compromised lateral wall? But what you would hear most of us talk about is not lateral walls as much, although you will hear lateral walls, but we like to classify them as stable or unstable fracture patterns. And now, looking at the way they divided these fractures on this page, it makes much more sense, because, and this is why I added what most people don't add, just say stable. But what do we mean by stable? We mean its length stable. It means these fracture patterns, if you think again of the neck, because of the neck area or the proximal femur area, just the proximal femur area, length stable means that you have a simple fracture pattern that cortex abuts cortex, and it's not going to collapse if you put a sliding hip screw, right? And this is the only fracture in the body when we actually want the screws to slide. We don't want them to be fixed. So all of these are stable fracture, or should actually be called length stable fractures, because we have a simple fracture pattern. Cortex abuts cortex, and you don't lose length once you put your sliding hip screw. All of these fractures are length unstable fractures, right? So it's either it's unstable because there's comminution and there's no cortex abutting cortex, and it just slide and shorten, or because the direction of the fractures is in a reverse direction, and then it's going to just slide off the shaft if you again just focus on the proximal femur area and the direction of forces that go through it. So it's length, but all of these patterns are length unstable. So let's do a little bit of, it's been a long time since we had a poll, so let's do a little exercise. So classify this, is this a 31A, so trochanteric area, 1, 2, or 3? And we are going to choose, quite simple question, 1, 2, or 3. And this is the trochanteric area. It's not the neck area. And all right, so we have some engagement. remember the stable versus unstable, the lateral wall versus compromised versus uncompromised. And we are in time. And the results, well, the vast majority thinks that this is an unstable A2 fracture with a compromised lateral wall. I think maybe that's the that's what drove you to this conclusion, but it's a stable one. And again, it goes to the fracture. So what you're seeing here in this fracture, it's a simple fracture line. You can almost see both sides. You can see how cortex abuts cortex, right? This is the main difference where you could say, and I'm not going to argue. You know, if you put a hip screw and you say, well, this is less than 2.5 centimeters or more, the lateral wall, again, you have to measure it from where a hip screw would go, right? So this, you can say, well, we can have this argument, but the principle is that you have to think length stable versus length unstable. So this is a length stable because you can see how the fracture line in the proximal and distal fragments almost mirror each other, right? So all it needs to do, you just need to reduce it, and it's going to be length stable. Therefore, you should get a DHS. And what's nice about this new modification is once you understand the principles of being length stable, this fracture, which previously we thought was, we will call, maybe someone would call unstable because of the comminution here. Again, because it's simple fracture lines, again, you could measure it. It's more than 2 centimeters probably. But the principle is that it's length stable. You have a nice surfaces that you can reduce to, control length, and it will eventually what you're seeing here is the 0.3 fracture, where you have a little bit comminution on the lesser troch area, but you have a huge surface which you can reduce the fracture to. So it's going to be a peritochonteric, intact lateral wall, length stable, and the implant should be a sliding hip screw with a plate construct. Okay, so that's I think a big change in this 2018 update, which makes a lot of sense. A little bit epidemiology. Second most common reason to be in the emergency room. First one is for a fracture is ankle. And you can see the intertrochanteric fractures happen in older people than compared to the femoral neck fractures. The peak is around age 80. And again, women more than men. Question. Your grandmother now is turning 90. Congratulations. And she asks you, what is her chance of breaking her hip next year? So not dying, but breaking her hip next year. And let's put the next poll up. I think it's this one. Nope. All right, so 90-year-old, what are the chances of falling, breaking her hip? Age group probably is she's going to get a trochanteric fracture, not a neck fracture, but who knows? All right, and we've got some engagement, 60%, one more person. Okay, 70%, nice, and 85%. All right, so everybody wants in on grandma, and this is, okay, we'll share the results. So most of you think there is a 30% chance of her breaking her hip. And let's see the correct answer. You are absolutely right. And this is based on a study that from 2012, which was a sample from all emergency rooms in the United States. And you can see, these are the numbers on the left, and you can see that around age 90, it's exactly 30% incidence for women and 20% for men. On the bottom, you can see that the risk of having an intertor compared to a femoral neck fracture is about twice as much in that age group. All right. So all about decision making, and again, this time this is again from the OTI decision making book, and this algorithm was written by Dave Shearer. But really, you can sum up the whole algorithm into one question now, that especially now that you know the classification, and that is the fracture length stable or not, right? The proximal femur area, is it length stable or not? If it's a stable fracture pattern, you go with a plate and a sliding hip screw. If it's unstable, not length stable fracture, then you go with a nail. And now you can also understand why you go with the nail, because all the nail does is prevent this from shortening. So this length instability from happening. It just puts the cortex 1 inch more medial to prevent this from happening. All right, question. A 75-year-old woman presents with the following fracture. The operating room asks you which implant to order: plate and sliding hip screw, cephalomedullary nail, blade plate, or proximal femur locking plate. And look, you classify the fracture, and there's only one answer that could possibly come to mind if you classified it correctly. Is it length unstable or length stable? And we are getting rapid engagement. 50% of people, 60, 70. Go, go, go. Yes. All right, enough. 20 seconds was enough. And we're sharing the results. All right, so overwhelming majority for femoral, proximal femoral nail or cephalomedullary nail. And this is because this is an extremely unstable fracture. You can see the lateral wall is broken completely, and there's comminution, and it's already showing you how length unstable it is, I think. But that's that makes sense. I guess if you got better imaging and you can convince yourself that it could be a length stable, there is cortex to cortex to reduce to, you can change your answer. This is okay. And this lady did get a nail, and this is 2 months later. She's healing it and very happy. So what are the controversies in management of trochanteric fractures? First of all, is how soon should we operate? Is it an emergency? Should we wait? Plate versus nail. We talked about it. If nail, how long should the nail? Short versus long. And then if you're using long nail, should we lock it distally or not? So plate versus nail, we already talked about. I think you got the answer. It's totally dependent on the classification. Nail, how long the nail is, we don't have a definitive study to hang our hat on, but we haven't been able to show any difference between any advantage of long nails over short nails. So most people are going for the short nails, which are just less time in the operating room. And then again, we don't have a definitive study to answer should we lock the nail distally or not, but all the studies so far have shown better results. I mean, there's a lot of studies showing better results with locking, and no malrotation, derotations, late derotations happening. But it's still controversial. You should know that, and yeah, I think it's another 5 minutes to the case. I would just say just lock distally if you're doing a long nail. So the only question that's really left is how soon should we operate? And let's try to answer it with a question. So sadly, your grandmother does fall and sustained a 3183 fracture, which is the reversible equity, if you remember. So why should we take her urgently from the ED to the operating room? A, because she's your grandmother. B, to reduce her risk to reduce heart attack, or to reduce her risk of death. So why should we take her urgently to the operating room? Oops, I am not getting better in this polling business. That's unfortunate. Okay, so question. Death, heart attacks, delirium, or just this is just plain favoritism, and we should take care of our own. All right, 80%. Oh, finally somebody knows how things work around here. Okay. All right, so end poll. Okay, so 2 people say we should take him because it's your grandmother, which may be true, but most of you think that it's really what we're reducing is the risk of death. So, lucky for us, there's great evidence now to answer this question. Oh, I didn't show you that. Okay, this is the results, yeah? So there's great evidence, and actually the answer is to reduce the risk of delirium. So a study called Hip Attack was just finished and was published in The Lancet in 2020. So great randomized control trials, one of the largest randomized control trials ever done in orthopedic history. You should definitely know about this study. So 1,500 patients accelerated, meaning taken to the operating room in less than 6 hours from coming to the ED, and 1,500 getting just the standard of care. And they tried to show that there's a difference in death or major complications. They couldn't demonstrate that. No p-values there. But, oops. But what they did show all the way to the bottom, you can see that delirium was by far the most statistically significant difference. They also showed there was a little bit less stroke and less UTIs. The patients got 1 day earlier out of the hospital. And maybe I'm missing another one, but that's an important study. So the only thing we can, if you want to take a patient that urgently to the OR, the only reason you can say is that you're reducing delirium, maybe stroke, maybe UTIs, and taking the patient. The patient also got a day earlier out of bed, but getting them out of the hospital and out of bed sooner. So important study. All right, let's continue with grandma. And now she is rushed to the operating room after getting a regional block. And you should know, although we don't have a definitive study for that, that fascial iliac block is becoming the new standard. So these patients are getting in the ED fascial iliac block to reduce their opioid intake. So she gets this block and is rushed to the operating room. But in order to further optimize her outcome, we need to A, keep her off opioids, B, keep her off the street, keep her in a surgical nursing facility, or keep her fracture from varus. And this is a stop sharing. All right, so your answer is all right, so it's a race all the way to the finish. We got a nice engagement. We're ending the poll and we're sharing the results. So most people, I think the anti-opioid campaign has been really effective, and most of you should say that we should keep her off opioids. And I think this is about partly a how to answer questions. So we definitely want to reduce our opioid intake because we know opioids have a lot of adverse effects, but we can't keep her off the opioids because it's still one of our most effective pain control treatments. So they have a role, especially in acute pain. Well, we don't want to have a chronic opioid use, but in acute pain, opioids are not going away anytime soon. It's okay to judicial use of opioids is still fine and part of most algorithms today. But keeping her fracture from going into varus or being fixed in varus is definitely being shown by multiple studies to be very important in good outcome, particularly harder failure. So if we fix her in varus, what happens after a while, the cantilever forces on the implant result in what you see here, which is an implant breakage, or more commonly a cutout. And speaking of cutout, talk about trochanteric fractures is complete without mentioning the tip apex distance, which is a measurement that was popularized by Michael Baumgartner from Yale University. And it's basically when you do any type of fixation that involves a sliding hip screw, nail, or plate, you want to keep that the screw inside the femoral head within, so the sum of the distances of the two views, AP and lateral, will have the tip of the screw and the center of the femoral head less than distances, the sum of the will be less than 25 millimeters. If you do that, you're going to decrease your chances of cutout significantly.